And again, all are on mute. However, if you have any questions during the webinar, please don't hesitate to type the question in the chat box, or we'll have a question and answer time at the end where you can press *7 to unmute your line. Also, following the webinar, we'll send everybody a link so that they can access the PowerPoint presentations as well as the webinar recording. And so this afternoon, we have a great lineup of experts who will be sharing insights around injury and cognition. The first will be Linda Anderson, followed by Judy Stevens, Lisa Dawson, Elizabeth Head, and then Amber Williams. And our first presenter is Dr. Linda Anderson with the Centers for Disease Control and Prevention.
Thank you so much, Lynn. I'm going to do a sound check to make sure that you can hear me.
Yes, we can. Thank you for joining us.
So thank you. I want to first thank the Association of State and Territorial Health Officers, ASTHO, for their leadership in really hosting this series of webinars on healthy aging, and thank in advance our speakers who are going to talk about falls and falls prevention. So let me begin by giving you some background information about healthy aging. And although there is no agreement about the exact age that signifies an older adult, for the purposes of my presentation, I focus on adults age 65 or older. And certainly this definition shifts according to a society as well as some of the programs. But this age is consistent with age eligibility for the Medicare coverage as well as older adult topic areas in Healthy People 2020. And as you can see on this slide, between 1900 and 2050, you see a large growth in this population. And at the beginning of the 20th century, there was about 3 million older adults who were age 65 or older, which was about 4% of the population. And in 2011, which you'll see by that dotted blue line we move up to there are about 35 million people age 65 or older, now about 13% of the population. And if we fast forward to what is projected, if things continue in the certain trends, by 2030, the proportion of those adults age 65 or older will more than double to about 72 million, which will make up about 20% of the population. So I think you can see just from this demographic trend what we're seeing in the future. What also is helpful is to think of a conceptual framework for thinking about optimal aging. That it's, again, we have a person-centered type of focus. We think about promoting health and preventing injury, the focus today, as well as managing chronic conditions. We can also see that we want to optimize physical, cognitive, and mental health. And you can see the connections between prevention injury and physical cognitive health. Really, and a goal is to then facilitate and continue social engagement of older adults. And again, by this we think of optimizing aging. So no matter where the person is, if they have functional limitations, we can always think about the ways to improve health and functioning. So I wanted to also share with you a definition of cognitive health. Like health itself in the World Health Organization, it's not merely just the absence of disease, but really cognition is the development and preservation of a multidimensional structure. And this allows, again, older adults to maintain social connectedness, to have a sense of purpose, to apply abilities to function independently, and then permit recovery from illness and injury, and then cope if there's any residual functional deficits. And so keep both that conceptual framework as well as this definition in mind as the speakers proceed today. But one of the things that we have been particularly concerned about is the growing increase in Alzheimer's disease. And in 2008, Alzheimer's disease, in terms of leading causes of death of all adults, overtook diabetes. And now Alzheimer's disease is the 6th leading cause of death. Additionally, I wanted to make sure that all of you are aware of the National Alzheimer's Project Act, and in particular the National Plan to Address Alzheimer's Disease. And each year there is an update, and in the next couple of months there will be the 2014 update. And I have the link here for those of you who would like to visit that. And again, as Lynn said, the slides will be distributed later. And then finally, I wanted to just briefly touch upon the Healthy Brain Initiative, which CDC has been working on since 2006 when Congress appropriated funds. We really work in the area of the public's perceptions about cognitive functioning, helping to build a strong evidence base, and then translating that information into public health practice. And more recently, we've developed a new initiative, a roadmap called the Healthy Brain Initiative, the Public Health Roadmap for State and National Partnerships. This is a 5-year plan which was developed using participatory methods with over 280 experts, including about half from the states. And it has 35 action items that public health community can do over the next 5 years. And I mention this because 2 of them are focused on falls. The first, under the area we call Monitor and Evaluate, is designed to look at surveillance data to enhance awareness and action in public health programming. And that would be in the behavioral risk factor surveillance questions we have on Cognition could be linked to issues around falls prevention. And then second, under Develop Policy and Mobilize Partnerships, the action item is to integrate cognitive health and impairment into state and local government plans. And in particular interest to this is really in terms of the falls plans and initiatives as well as transportation. So I wanted to point these out because this work really has moving forward these action items for public health. So with that, I'll end my brief presentation, but if you're interested in finding out more about the Healthy Brain Initiative, I've included the following slide and contact information. So thank you.
Great. Thank you so much, Dr. Anderson. And next up we have Dr. Judy Stevens. She's a senior epidemiologist with the Division of Unintentional Injury Prevention at the National Center for Injury Prevention and Control at the Centers for Disease Control and Prevention. Dr. Stevens, we can't hear you yet. If you could press *7 to unmute your line.
How's that?
Yes, perfect.
Okay, I didn't think to do that since I had it muted at my end. Okay, I'm going to be talking this afternoon about preventing older adult falls. And as we just heard from Dr. Anderson, our population is aging rapidly. Every day, 10,000 more people turn age 65. And the older adult population is expected to more than double between now and 2040. So to give you some background about falls and the extent of the issue, falls are the leading cause of injury-related deaths and emergency department visits for people 65 and older. About 1/3 of older people fall every year, and those who fall are 2 to 3 times more likely to fall again. Roughly 1 in 5 falls causes a serious injury, such as a fracture or a head injury, and these types of injuries can limit people's ability to get around and to live independently. In 2010, the direct medical cost for falls when they were adjusted for inflation was $30 billion. Now, a fall risk factor is something that increases a person's chances of experiencing a fall. And this can be a biological characteristic such as age, a behavior such as climbing on a ladder, or some aspect of the environment such as a tripping hazard, any of these that increase the chances that a person will fall. Now, an analysis of 16 controlled studies that are shown here identified 8 fall risk factors as the most important. You can see them on the table. And the relative, the relative risks range from 2 to 5 times increased risk of falling. And I've highlighted, you can see that cognitive impairment is on this list with a relative risk of 2.4. Most importantly, many of these factors can be modified. And we know that by modifying or reducing risk factors, we can reduce the incidence of falls. And there's good evidence around fall prevention showing that falls can be prevented. There have been a number of systematic reviews and meta-analyses that have been published and have identified effective fall interventions. And I've listed these studies, these meta-analyses on the slide. Effective interventions include exercise that improves strength and balance, multifactorial interventions that include a number of areas that address risk factors such as exercise, medication review, and home modification, vitamin D supplementation, and clinical risk assessment and treatment by healthcare professionals. Unfortunately, the studies of falls interventions for people with cognitive impairment have been limited. The most effective intervention seems to be a comprehensive clinical assessment followed by treatment of identified fall risk factors. But there has not been a lot of successful work in this area. Now, CDC is supporting 3 evidence-based community fall prevention programs, and I've shown them here. Tai Chi for Moving for Better Balance is designed for healthy adults 60 and older, and it's held in senior centers or similar types of venues. People in the program learn 8 forms or body movement exercises, and they're generally 1-hour classes offered 2 to 3 times a week for 12 or more weeks. Another Stepping On is a behavioral program, and it was developed by Dr. Lindy Clemson in Australia and then adapted for the U.S. by Dr. Jane Mahoney, the University of Wisconsin. It's intended for somewhat higher risk people than the Tai Chi program. And then there's the ASTHO exercise program. This is a home-based, individually tailored program of progressive strength and balance exercises that are prescribed by a physical therapist. And it's designed so that the exercises become more challenging over time. And this program is really designed for frail older adults. Now, the clinical approach, which I mentioned earlier, is very effective, and it involves a clinical assessment by a physician or healthcare provider to identify and treat that individual's specific risk factors. And this can involve referring patients to specialists, such as physical therapists or podiatrists. But unfortunately, not many providers are focusing on fall prevention. To help with this situation, to help healthcare providers incorporate fall prevention into clinical practice, CDC's developed the STEADY Toolkit, and this stands for Stopping Elderly Accidents, Deaths, and Injuries. The toolkit contains resources for providers, such as fact sheets, case studies, and guidelines for talking to patients about falls. That is based on the Stages of Change model. And it also has tools to assess gait and balance. There are resources also for patients, such as a validated self-risk assessment brochure and educational materials about fall prevention. And these materials can be found at cdc.gov/injury/STEADY. So all these materials are out there for download. We don't have any in print at the moment. Now, one of the things that we are wanting to do is to link primary care with the community programs. And CDC is currently funding 3 states to use this type of coordinated approach to reduce falls in selected communities. So each state's implementing the 3 programs I mentioned, Tai Chi Moving for Better Balance, Stepping On, and ASTHO, as well as getting STEADY implemented in healthcare practices. And the goal, as I've indicated here, is to link practice clinical practice with the programs so that patients who are at low or moderate fall risk can be referred to one of the community programs, while patients who are at higher risk would receive more individualized clinical care. So what are our next steps? We need to translate more proven interventions into new community programs so that they're more available. 3 is not nearly enough. We need to disseminate and promote the widespread adoption of the evidence-based fall prevention programs we have now and new programs as they become available. And we'll need to evaluate how well study worked to change clinical practice and to link primary health care and community fall prevention programs. So thank you very much. I don't know if we're going to, are you saving questions for the end? Is that how you want to do this?
We'll save most of them, but we actually had one just come through the chat asking what the 3 states were that you were.
They're Oregon, New York, and Colorado. Should have said that sooner.
Yeah, great. Thank you very much. And again, for folks, please feel free to ask any questions through the chat, and we can discuss them as the presenters are transitioning or at the end of the call. So thank you very much, Dr. Stevens, for your presentation. And next up, we have from the Georgia Department of Public Health and the Injury Prevention Program, Lisa Dawson and Elizabeth Head. We can't hear you. Okay, we see the slides going, but can't hear you. If you could press *7 to unmute your line.
Can you hear me now?
Yes. Yep.
Okay.
Great, thank you.
Okay, so sorry about that. Again, this is Lisa Dawson. And Liz, are you on the line as well? Let's make sure we can hear you.
I am. Can you hear me?
I can. Can the chair hear?
Excellent.
This is Lynn. I can hear you. Thank you.
Great. Fantastic. Thank you so much to the Association of State and Territorial Health Officers for having the call. I feel like we are very privileged to be in this group of presenters. Our charge was to give a state perspective on fall prevention, and so today I'm just going to briefly touch on the history and the framework. Liz Head is going to go over the specific activities, and then we'll be happy to entertain questions either after our presentation or at the end. So the thing that we learned about the aging process right away, and we didn't learn this actually in falls, we learned it in our older driver coalition, is that you can be 85 years of age and have many faculties in fine shape, and you can also be 60 years of age and not be in the best of shape, either physically or cognitively. And for those reasons, we learned a whole lot about working with our Division of Aging Services in looking at ways to prevent injury in that population. I really appreciate this chart that we've got up, the physical and cognitive impairments, because it really charts out for you the normal aging process and the decrease in all of the aspects that are important that we would want to address in injury prevention, but then it also pairs it with the disease processes that you have a great risk of onset as you age. And so it really neatly puts together some of the risk factors and the protective factors pretty quickly. So our program history and framework is that we have, in 2008, we still had Preventive Health Block Grant dollars, and so we started paying a part-time person to help us convene the Falls Coalition with our partners in the Division of Aging Services. We really were starting with collective impact in mind. We wanted to be organized. We wanted to know our data sources. We wanted to know who was already doing any type of injury prevention work or fall prevention work in the state. We were very fortunate that Kaiser Permanente showed an interest early on. We decided that in addition to networking and getting those activities done, we wanted to create a plan, and we wanted to engage our partners in a way that was meaningful for both us and them. And we were starting to look at the implementation of evidence-based programming. I really appreciate this list of partnerships. We also put in some of the bubbles that relate directly to a resource that has already been discussed on the call at a previous presentation. So that's what the P02 is. But you can see by this list that we have truly got a wonderful diverse representation across the state. What we don't have is a lot from outside the Atlanta metro area, but we're working on that because, as you know, in your states the rural and the metro areas are often quite different, and outside of Atlanta it's still Georgia. The last thing that we learned about, and I don't think that this was something that we knew well at the Public Health Department before our collaboration with the Division of Aging Services, was the area agencies on aging and the disability resource connections. We have really utilized that as a medium to get out our messages that there are evidence-based interventions and to engage local partners. It is an excellent medium, and at this point I think I'm going to turn it over to Liz to help fill in the gaps about why that has just been a terrific collaboration.
Thanks, Lisa. Truly, when we think about older adults and aging and the services that we need, we're very lucky in Georgia to have an aging and disability resource connection that goes pretty well across the state. And so we rely on these folks as well as our Division of Aging Services partners as we look to implement some of the evidence-based programs that CDC represents or that recommends. We have the Falls Coalition that Lisa mentioned that was created in 2008. We have partners all completely across the state in this all-volunteer effort at not only educating professionals across the state about falls risks and interventions that might be available, but also getting all the way down to our members of the community and helping them to find the resources and programs that they need in order to reduce the risk of falls. Specifically in Georgia, we were funded through a CDC core grant to work a little bit on capacity, and included in that was building our capacity to implement Stepping On, which, as Dr. Stevens described, is an evidence-based program developed in Australia and adapted for use in the United States. We're managed to get one trainer trained, and she's done a fabulous job with doing the program throughout the state. Some of our challenges with Stepping On are pretty much that we're a very large state. We've got 159 counties. Probably other states would tell you that it's not always easy to get a peer leader to help from class to class, so it becomes like starting over. But overall, the implementation, given our challenges, went really well. We're very excited that in addition to Stepping On, through our partnership with the Division of Aging Services and also our AAAs around the state and ADRCs have been trained to be matter of balance lay leaders, and that has gone off throughout the bulk of 2014. So Georgia has quite a few of those classes going. More people are being trained. It's really a unique opportunity to work with the Division of Aging Services and get prevention out into the community. More exciting still is our ability to bring Tai Chi into Georgia, hopefully in late 2014 or early 2015. We're looking to get folks trained again through our partnership with the Division of Aging Services and working with the area agencies on aging across the state, we will be able to work on Tai Chi and get that out and get folks trained to do it. A lot of lessons learned, and most of that is to really educate our partners and make sure that they have the tools that they need to work on fall prevention. Very excited to talk about the Georgia Alzheimer's and Related Dementia Task Force. This was created in the 2013 and 14 regular session. Basically, we are looking to create a comprehensive state plan for Georgia to address Alzheimer's and all related dementias. We had 6 teams that came about, and they met throughout 2013. Our Department of Public Health sat on a couple of the teams. Specifically, we sat on the public safety team, and were able to make some recommendations on these things: abuse, neglect, and exploitation of older adults, driving safety, wandering, in-home safety, and disaster preparedness. Specifically in in-home safety, a recommendation has made it at least into the draft guidance for the state plan that STEADY be implemented in practitioners' offices. We do recognize that STEADY is not specifically addressing fall risk for those with cognitive issues. However, it's a definite and positive step in the direction of linking clinical practice with prevention. We're very excited about this step. I'll let Lisa talk a little bit more about what we plan to do in the future. We've got a couple of opportunities. Being a decentralized state with so many counties, 159 of them, over 600 law enforcement agencies, decentralized courts, coroners, and medical examiners, we are looking at reaching out through a new telehealth system with the Department of Public Health. I love that Liz put this in this slide about promoting mobility, common risks, interconnected solutions. Cognition is an issue across every single injury mechanism. And the more we can leverage what we know in one injury area to other injury areas, the more efficient and effective I think that we can be. We are really looking forward to working with our medical partners, our ICRIC. We have Emory Center for Injury Control, which is an amazing partner, as well as the Center for Aging at Emory. And as I mentioned earlier, Kaiser Permanente. We are really looking forward to having opportunities for them to help us. So we feel like we built a pretty good foundation with very few resources, and we're looking forward to moving ahead on that. You can call us, or you can see us on the web. I think that's what we had, Lynn.
No, and that was plenty. Thank you so much, you both, for sharing those insights with the group. And we've had quite a few questions come through, so we're going to go to the next presenter so that we don't run out of time. And I want to assure everybody that if we don't get to your question during today's webinar, we will definitely follow up to answer those questions. But for now, we'll move on to make sure that we have some time at the end to address questions and allow all of our presenters to share. So next we have Amber Norris-Williams, and she's the Executive Director of the Safe States Alliance.
Hi, everyone. This is Amber. I'm hoping you all can hear me.
Yes, we can.
Great. Thank you for inviting us to be part of this call. We're really excited to be able to connect to the healthy aging work and present some of the work that we've been doing at Safe States Alliance. For those who are not familiar with Safe States, we are a national association of professionals who work in state and local health departments, hospitals, universities, and other settings, and are focused on strengthening the practice of injury and violence prevention. We have done a lot of work in the area of falls among older adults, and my purpose in being here is really to talk about some of the efforts of Safe States in working with our members and our partners, particularly at CDC, to share with you what we've learned and where we might be going in the future. So I'll just jump right in, and I hope to save everyone some time for questions, because I know there are many, because there are some things that you've already heard and that just are not needed to go into. So I think Dr. Stevens did a great job of talking about why an organization like Safe States and the members that we represent are so concerned and have been so concerned about the burden of falls and what that means for priorities that we set as national and state and local organizations in terms of how we address public health issues, including falls. So what I wanted to show you is how Safe States, one of the things that we do is collect information about what are the focus areas of particularly state health department injury and violence prevention programs. We've been conducting a study called State of the States since 2005, and we're currently collecting 2013 information and cleaning it. So I only have for you information between 2005 and 2011 on this slide. But it shows you, I think, very clearly how programs have really recognized this rising burden of falls and have begun to change their prioritization. And you can see in 2005 and in 2007 it was 6 and 7 among the state health department programs. But in 2011 it jumped up to number 2. And I think this is for a number of reasons. The burden, the increased recognition by our federal partners, and then beginning to see some increased resources in this direction as well. So some of the things that we've been doing on a national level, we began a lot of our work in 2006. We held a roundtable with the Society for the Advancement of Violence and Injury Research on elder falls prevention. And really what we wanted to do was really have a better idea of what state health department programs and researchers were doing in the area of falls among older adults. Think about what strategies were needed to prevent falls in the future, and where there were opportunities for practitioners and researchers to continue to add value to the work being done, and where it was needed in the future. We also began some discussions about what resources and cross-cutting infrastructure would be needed to accomplish goals of reducing falls among older adults. So that was one effort that we took. Following that, we convened an injury surveillance work group to help us provide recommendations to injury professionals on how they can report on the burden of fall-related injuries in their states. And this encompasses all ages. It's not just for older adults, but does help in standardizing reporting across states so that we can begin to have a clearer picture of what's happening not only in states but across the nation. Through State of the States, we began to look more in depth at what are the activities that states were engaging in related to falls prevention. And then we began doing some additional work around raising the visibility and being a better advocate for the resources that are needed for falls prevention. And so a couple of those activities included holding a congressional briefing on falls prevention, and then serving as a member of the Falls Free Coalition, who really serves as a strong advocate for really thinking about what investments are needed for moving forward. They also do a lot around an annual Fall Prevention Awareness Day. Currently, we are really thinking more about how we align with the new opportunities through the Affordable Care Act. Certainly, the screening of falls is now included through an assessment that can be done that Judy mentioned, and that is definitely something that we're trying to promote. And also thinking about how are we supporting programs in the conduction of those evidence-based programs. So one of the things that we did began back in 2009 was work with CDC in looking at state implementation of evidence-based programs. And so Judy mentioned there were 3 programs that they began trying to support state implementation efforts. And what they wanted to know was, what are the barriers, what are the facilitators, and what other lessons learned can be shared as we try to increase the scale of these evidence-based programs that we do know that exist already. So we provided training and technical assistance. We conducted the evaluation and then helped CDC in developing new tools. So some of the things that we looked at were, how did they implement these programs? So it was Tai Chi, moving for better balance, and stepping on. What were the implementation strategies that were chosen by the states, and how did that either facilitate or pose barriers? So with the State Health Department serving as a lead in selecting local sites, who was responsible for local coordination? What funding was provided to the local sites? What were the background of both the participants and instructors? And we also looked at what was the sustainability, scalability, and the fidelity of their implementation, as well as the participant outcomes. So those were state-specific reports back to us. We didn't follow individual participants. We just collected the information from states. So very similar questions for stepping on. And then these resulted in reports that we shared with all states to help inform their future implementation efforts. And the other thing that came out of this is what Judy mentioned about having funding for 3 state programs to, again, implement those programs, but also expand some of their work with STEADY and the Otago exercise program. So as we think about where Safe States is moving in the future and where we can best support falls prevention with other public health and other multi-sector efforts, I think that some of the things that we're thinking about are, we work a lot in public health around improving walkability of communities and increasing access to transportation alternatives. And certainly those are very related to fall prevention. Lisa brought up the link that they found in Georgia between thinking about older adults and cognitive issues related to driving, and certainly that's an issue. As we begin thinking about taking away car use as a transportation alternative, there's certainly the need to have infrastructure in place for older adults to continue to access community services and be active in their communities. We've done some work with other national organizations around trying to strengthen the linkages between osteoporosis efforts and fall prevention efforts. And certainly thinking more about the linkages between some of the prevention activities that have evidence in preventing falls and where there is evidence to support other public health priorities such as depression. So I think that there's a lot of opportunity for better integration and linkages between the work that we're doing. And with that, I think that's all from my end, and I'd be happy to answer any questions, and I would also be happy to provide any of the links to any of the resources I've mentioned.
Great, thank you so much. And thank you again to all of our presenters who presented this afternoon. We know this is a very busy time, as are all times, and so really appreciate all of them taking the time to present, and appreciate all of you participants who are joining the call today. So as I said, we've gotten quite a few through the chat, so I'll do a few of those, and then if folks do have questions that they'd like to say verbally, please feel free to press *7. One of the questions that was asked of Judy was, are the components of the Otago exercise program available outside the demonstration the CDC is supporting?
Am I unmuted?
Yes, you are.
Okay, good. There is an online training for Otago, and unfortunately I don't have that link at my fingertips, but I could send that to you if you wanted to send it to a range of people who are interested in learning more about Otago.
That would be
work?
great. Yeah, this is Lynn, and I can include that in the follow-up email that we send folks.
Okay,
So
I'll get that to you.
Along with the webinar recording. Okay. And then we had a question for the Georgia team. Has there been any inclusion of home health agencies in Georgia?
Hi, so this is Liz. Home health has really only been represented on our task teams and on our coalitions. We actually don't have anything formal going on right now. Was there a specific kind of idea of their involvement? If they want to ask a follow-up.
I don't see anything coming through. If whoever answered the question would like to add more through chat or phone, please press *7. And in the meantime, we had another question for Judy. You mentioned little existing evidence for falls prevention strategies specific to people with dementia, cognitive impairment, and yet we know this is a significant risk factor. Any suggestions on falls prevention approaches based on perhaps emerging evidence, even if there's nothing evidence-based yet?
Sure. What I have, what I know about is limited, but it seems that for people who are mildly cognitively impaired, if they have a caregiver, then a multifactorial approach is more effective and can help prevent falls. But without the caregiver, the process doesn't seem to be very effective. The other approach, and I think this is pretty much across the board, is environmental changes to just reduce the chances of falling from, tripping or slipping. So having the house as safe as possible and eliminating fall hazards. But it really is quite limited. There's a little evidence that exercise can be helpful, but it's really a field that needs a lot more work. And there was another question, and I'll just jump ahead because I think it's probably of interest to other people. Question about what does it cost to implement these programs? And from a program perspective, we're in the process of finalizing a paper that looked at implementation costs, that included training and materials and advertising and so forth, to see what the return on investment is of a cost benefit. And that should be published in about 6 months. It looks quite positive. It doesn't take into, it's not a full-blown economic analysis. It doesn't take into account the costs that, say, a participant might incur, to drive to or take transportation to a location, that sort of thing. It's strictly from the program implementation perspective. But that should answer a lot of people's questions. I know we get that question quite a bit, and it'd be nice to be able to have a good answer. Any others?
So this is Lisa Dawson. Can you all hear me?
Yes.
Okay, so a couple of things, and I'm not sure if this is visible to everybody or not, but Jennifer Curry, a shout out to our Atlanta Regional Commission partner for reminding us that the area agencies on aging have a direct link to home health in each of their respective regions. So thank you, Jennifer, for reminding us of that. Alan Abe had asked if we had any partnership with EMS, and actually we've had several concurrent presentations by our Chief of Emergency Medical Services, Keith Wages, who has been talking a lot about community paramedics and what the potential might be for using the community paramedic model to do some injury prevention, particularly among this population. And so we're looking very closely at that and very closely at a pilot of the community EMS model that's going on up in the Gainesville area.
Great, thank you. I'll keep going through the chat ones, but we'll take a moment. Would anybody like to ask the question verbally by pressing *7 to unmute your line?
Hello, this is Brian Bentley with Nature Coast EMS in Florida. How's everybody doing?
Hi, doing well, thank you.
Excellent. We at Nature Coast EMS here, we are on probably about in the middle Nature Coast area, and I am actually a community paramedic, and we have been doing community paramedicine since October 1st. My question was about Tai Chi. We already have the Matter of Balance classes. We have put 12 instructors last month through the Matter of Balance classes. We have 9 full classes already, but the Tai Chi classes are very hard to get trained for, especially since the only training is up in Oregon. How did you facilitate the training for that?
Is that question for me?
Whoever could give me the answer of how to get a trainer down here to train us.
Well, are there any Tai Chi masters available? We've come to to believe that the type of Tai Chi is of less importance than the fact that it's tailored for older people.
Correct.
And example is Tai Chi for arthritis is a program that is much more widely available, and that appears to be equally useful for fall prevention. Is that of any help?
Well, even in our Florida Injury Prevention Advisory Council meetings, the subject of Tai Chi training for the moving for better balance has been extremely challenging, and that's why I would like to know what you and Georgia did to facilitate that training.
Hi, this is Liz. We are working right now to figure out the best route to get that training.
Okay.
I do know that our partners in Division of Aging Services, they did reach out to Dr. Lee in Oregon.
Yes.
There is a very limited number of trainers that he is even willing to train.
Yes.
There's another, and Dr. Stevens, you might be able to help me with this, Suman is in Lee, I think is his last name. No, Suman is his name, is a trainer that you can also request to come out and be trained, and that's what we're currently looking into.
Is that Dr. Lee from Oregon still? I'm sorry.
Yes, Dr.
Okay.
Fuzhong Lee.
Yeah.
So that's what we're looking at. And to Judy's point, actually, given the potential challenges with training for Tai Chi, we're actually looking at potentially doing a Tai Chi for arthritis type of scenario.
Okay. Now, do you know if that involves the same 8 evidence-based exercises that are in Moving for Better Balance?
Well, as Judy was saying, with Tai Chi, it matters less about the specific type of Tai Chi than it does that it's been modified for the use by older adults with impairment.
Okay.
And I do know that the arthritis has been modified for that. Unfortunately, I'm not familiar with the specific forms that are in that program.
Okay.
The one caution I would place is that there are some Tai Chi programs that are seated, and unless that's sort of a temporary beginning point, people would need to be able to stand. And if it's only done as a seated exercise, then it wouldn't really be helpful for fall prevention.
See, and that is the exact opposite of what I just heard last week. As a matter of fact, the Moving for Better Balance, they do recommend whatever you can do, even in a seated position. That would still, they would recommend that as well. So, I appreciate you guys.
For Moving for Better Balance.
Yes, ma'am.
Saying that?
Yes, ma'am. I know we do have one class that is up in right beside Tallahassee, where they only have about 20,000 people, and they have about 30 people show up each time, and that is the only one that I know of from my resources at the Florida Injury Prevention Advisory Council that I know of in the state. So.
This is Jennifer Curry from Georgia, and if I could just add one thing about that I just heard, and I wish I had my notes in front of me, from a national call with the NCOA Falls Free people, and it was to echo what Judy and Liz already said about the type of Tai Chi, and I wish I had it in front of me, but it really had to do with how often the Tai Chi is done.
Okay.
Not just that it was, but that if you're going to say that the evidence shows Tai Chi reduces falls, it has to be done in a certain way, a certain amount of times per week. And like I said, I'm afraid I don't have that in front of me, but certainly we could get that from the National Council on Aging. And then
I think I can probably answer that.
Sure.
I didn't really want to get into it, but it's actually the cumulative amount of hours before it really becomes effective as fall prevention. Any type of exercise that addresses gait and balance the way Tai Chi does. And it's accumulation of 50 hours of practice, which sounds really intimidating, but if it's 1 hour twice a week for 6 months, that's your 50 hours or more. So it's an ongoing process. It's not a 6-week, fix it, then you're all done kind of situation. For fall prevention, it really needs to be ongoing.
Well said.
I do appreciate you guys answering my questions. I do apologize about interrupting, but we are pretty knee deep in the injury prevention in Citrus County, Florida, where I'm from, and just appreciate all the information.
Absolutely.
And this is Amber. I just want to say that I think this drives the point that Judy brought up home, in that with only 3 evidence-based programs for us to disseminate across a nation in need, it's very difficult to have the resources to scale it up in any sort of a way that is going to maintain the fidelity and help us in making sure that these programs are being implemented as they were evaluated. So I think that that's one of the things that Safe States is really concerned about, is how are we able to support programs like these so that they can be scaled up and used in communities across the U.S. So we value our partners at NCOA and others who are helping to fight that fight with us, but it's a huge issue.
Well, I appreciate that you guys are looking into that, and to us boots on the ground type people who come in contact with these frequent loyalty customers every day, that we get to pass on that information.
Mm-hmm.
Hello. Good afternoon. This is Audrey Brzezinski, and hi, Brian.
Hey, Audrey.
I'm also on the Gold Team program. I'm down in Hobe Sound, Florida, and we are a community-based fall prevention program. We've been following the CDC guidelines. I have been trained by Dr. Lee and Suman Barkis when they've both been here, and I currently run 2 Tai Chi Moving for Better Balance programs. And my question is, to maintain the fidelity of the Tai Chi Moving for Better Balance, I keep all my records, and yes, they do meet twice a week for an hour, and they do an hour of homework over the course of the week, just reviewing their warm-up exercises and practicing the forms. But to now say that we can just recommend any Tai Chi, I try to keep the fidelity of the Tai Chi Moving for Better Balance, which is evidence-based, and still say, go do any kind of exercise. Yes, it will help, but we're not maintaining the fidelity then.
Well, it's not just any exercise.
Well, the Tai Chi, when I recommend the Tai Chi for Parkinson's, because I run into that a lot, and Tai Chi for arthritis. So we're trying here as a little community-based nonprofit, and I'm so incredible that we have been working on the same problem, but not realizing that there was so much help out there.
Great, thank you. And I think we have time for one more question, so I'm going to ask one that's come through the chat box, and if your question has not been answered, don't worry, I will follow up with the presenters and make sure that your question gets answered. And also following the webinar, again, we will be sending out the recording as well as the PowerPoints from today. So one question that has come through, and I think a lot of folks probably have questions about, are whether there are any identified payment sources for Otago.
I think, and Sally Thorson generously put the link into chat. So that's you have that now. There are some payment sources. There are ways of getting paid to do Otago for physical therapists, and I believe that that's incorporated into the training. So I would say take a look at the online training and see if that answers your question. And if not, I can put you in contact with Tiffany Schubert, who is a physical therapist who developed that online training, and I know that she has worked on that particular aspect, because the difficulty with getting Otago implemented as an at-home individualized fall prevention program is the reimbursement issue. And so that's really important, and there are ways of getting paid to do it.
Great, thank you. And in the interest of everybody's time, we are going to come to a close. So thank you again, everyone, for joining and presenting this afternoon, and for all your great questions. Please just take a moment. Once you close the boxes here, you'll be taken to a survey evaluation, so please fill that out so we can continue to improve our webinars around this topic. You can include any feedback there, or feel free to contact me through email or phone. Also, we have a webinar coming up next week on March 25th at 2 p.m. Eastern Time, where we will focus on cognition and physical activity. So again, thank you very much for joining. Please fill out those evaluations and don't hesitate to contact me with any questions.